Welcome to the Fusionary Health Podcast. I have an incredible guest in store for you, Dr. Stephen Barrett. And Dr. Barrett and I are going to talk about diabetes, peripheral neuropathy, and all the different issues that affect diabetics and different ways we can approach healing those issues that we may never have heard of. And so, welcome, Dr. Barrett. How are you?
Oh, I'm great. Thanks for hosting me. And I look forward to having a great chat with you.
For sure. So, will you kick us off with explaining who you are, why you got into this, and what you're doing now in terms of your work with this topic?
Wow. Okay. So about, well, let me explain. So by training, I'm a podiatrist. I had always specialized in lower extremity reconstructive surgery, the usual things like orthopedic foot deformities, those types of things. And in about 1999 or 2000, I crossed paths with a gentleman who's a retired professor of plastic and neurosurgery at Johns Hopkins. And his name's Lee Dellen, and he was really instrumental in my professional life as well as personal life. But um, he had discovered in the mid 1980s that most of the symptoms of diabetic peripheral neuropathy were caused by superimposed nerve compressions. Because in diabetes, when people get to the point that they have neuropathic symptoms, their nerves swell. We can talk a little bit more about that, when we dial in on it. But to get back to the story is that in the mid 1980s, Dr. Dellen discovered that some of his patients that came in for hand surgery, when they had their carpal tunnel surgery done, their pain went away from the carpal tunnel problem, but they also came back and said, you know what, I've got sensation in these two fingers and half of this finger. And what was taught in medical schools then, which is still being taught today, ironically, is that once you have diabetic peripheral neuropathy, there is nothing that you can do to make it reverse or to really take care of the problem. And the answer is that that's really erroneous. There are many things that we can do, and we're going to talk about it today with peripheral nerve decompression surgery. But before we get into that, I think it's real important to realize that what we're talking about today is not new stuff. It's 40 years old, but it's still new because mainstream medicine has really not picked up on this. And that's the purpose of why I wanted to come on your show today, is to get the message out that there is hope and that there are a lot of things that can be done as far as preventing ulcers, ulcer recurrence, quality of life, protective sensations. So we can talk about those. But that's kind of how I got here today. And then over the last, really almost 25 years now, I've had pretty much a 90+% focus in peripheral nerve and peripheral neuropathy. So I don't and haven't practiced regular podiatric surgery since probably at least 15, 20 years ago now.
Got it. Okay. Well, for the audience, in case they don't understand what we're talking about, let's take a
Right.
big step back.
Okay.
Diabetes, as we know, is a chronic metabolic condition that so many people suffer with. Will you talk about how many people suffer with diabetes and what diabetic peripheral neuropathy is?
Yes. So that's a great question. And it depends on what statistics you look at. But let's take the number that's being floated around that in the United States, by the end of this decade, 2030, there'll be more than 30 million patients with diabetes type 2. And that number is probably conservatively low with our lifestyle and our diets and the processed food and all of the things that we're subjected to. The incidence is going to go up rather than go down. And it's estimated that about half of those people will develop what's called diabetic peripheral neuropathy. The term peripheral neuropathy is a really bad term because neuropathy doesn't really mean anything other than there's a problem with the nerve. So it doesn't tell us really what the mechanism of action is and what's really going on. But it just means that there's a problem with a nerve in somebody who's diabetic. Now, the metabolic process in diabetes and why these folks develop neuropathic symptoms. And neuropathic symptoms can be pain, loss of strength, balance, for example, shooting pains, sensation, loss of protective sensation, which is one of the really important things, because once you cannot feel what your foot is encountering, you can't protect yourself. Your protective mechanisms are gone. And so that's what leads to the development of ulcerations in patients with diabetic peripheral neuropathy. So let's go to the metabolism a little bit. So basically what happens when we have a situation where there's a metabolic impairment of carbohydrate metabolism, the nerve itself will get overloaded with too much glucose, and there's a pathway called the polyol pathway. And trust me, I really have a hard time with organic chemistry and biochemical pathways, but I have a fair understanding of this. But anyhow, what happens is that one of the enzymes gets overloaded and it can't metabolize inside the nerve itself. So the glucose becomes another sugar called sorbitol. And sorbitol loves water. It's what we call a hydrophilic molecule, meaning it just wants to bring water to it. Unlike glucose, which has a glucose transporter in the cell membrane, so think of that as a gate in the fence to let glucose in and out, sorbitol doesn't have that type of a conduit or a receptor to pass sorbitol through. So what happens is it draws fluid into the nerve itself. And so diabetic nerves are about 50% bigger in cross section than non-diabetic nerves. And this is very well proven. The literature is replete with ultrasound imaging showing this process. Now, most of the nerves in our peripheral nerve system go through tight tunnels. The most common is the carpal tunnel in the hand. And then we have those same analogous tunnels in the lower extremity. The lower extremity usually manifests symptoms much earlier than in the upper extremity. And we can talk about that if you have any interest in it. But basically, people will say, well, it starts out in my toes and now it's coming up, into my foot, my lower calf, and, ultimately comes up higher up. Usually that all happens before they start to manifest a symptom in the upper extremities, particularly in the hands. Now, one exception is carpal tunnel. So to give you an example, carpal tunnel syndrome occurs in about 2% of the population, U.S. population. But in the diabetic population, it's anywhere from 14% to 28%, depending on the article you read. So that's a significant order of magnitude. And that illustrates what's going on with this nerve that is swelling so much, and it's getting caught in this tight tunnel. So that's kind of the whole process there. Now, one thing I always have to be really careful with, and what we kind of got into a little bit of trouble, not me personally, but the folks that are doing this type of work, is 20 years ago, 25 years ago, when this first started catching on, a lot of people would say, well, we're operating on diabetic peripheral neuropathy. And the answer is no, you're not. Okay. Diabetic peripheral neuropathy is a systemic condition, just like we described. And it is the procedures we're going to talk about don't do anything to change the metabolism of the human being. Basically, what we're doing is taking a swollen nerve that's pinched by a tight tunnel, and we're opening that tunnel. Now, the beauty about that is that a lot of people believe that diabetic nerves can't heal. Well, they do, and they do heal, and they can heal very well, albeit it may be slower than a non-diabetic nerve. So when you take the pressure off, now all of a sudden this nerve can start functioning pretty well. So that was a really long-winded answer to your question, but
my audience might be wondering why I have you on my podcast, and it's so interesting. It's a very specific topic, right? This is a surgery specifically for diabetics who are suffering in their hands or feet or legs and arms around these issues. But my history is that my entire family is diabetic. And growing up, I watched my mom suffer with her diabetes, go to endocrinology, nutritionists, the gym, coaches. And now decades later, looking at diabetes in her body, her legs are chronically swollen. She's dealing with different issues, always that foot pain issues.
Right.
Doesn't matter that we got her double knee replacements. It doesn't, she's not able to really walk and move at the level I would like. And when
Right.
it comes to what you're talking about with neuropathy and protective, we take it for granted. We take it for
Right.
granted that we can just walk, and if I stepped on a pebble, it would hurt, and I would change my behavior and I'd address it in my feet. But my own grandfather, my paternal grandfather, who was a great man, he was so successful, such a great person in the community. He was the president of the Rotary Club of New Delhi, India.
Wow.
I'll never forget, I showed up in India and his leg was amputated. And I
Hmm.
was like, what happened?
Right.
He's bedridden now. He can't function. And they were like, oh, he was riding on a three-wheeler scooter. We have all those scooters in India, and his foot was off the side, and he had no idea that it
Right.
was cutting him. And so he went to the hospital. And of course, if you have advanced diabetes, you're not going to heal the same as the rest of us.
Right.
And he lost his leg.
Right.
And I've seen this with blindness and things. So will you take a moment just to explain the end game of diabetes and how horrible it is? Because I know that personally, and it directly changed the trajectory of my life. It's why I teach health and I obsess over health and I became a practitioner of health,
Right.
because I can't have other people suffer watching their parents and grandparents suffer with diabetes in this way. So although this topic is so specific today, I think it's so cool that you're talking about something that most people have never heard of. They just
Right.
think, oh, I have carpal tunnel. Oh, I have, these swollen feet and everything. And I have all these feet issues, but I have no choice. And I
Right.
love options for us that we've never heard of that we can apply to ourselves.
Right. No, that's very good. Um, I think even though what we're talking about is a very specific topic, but if you think about it in the global perspective, how it really plays with what we're trying to do from optimizing patients and humans' health. And so think about what kills more Americans over the age of 65 than any other thing. And a lot of people will say, well, it's cardiovascular disease or it's cancer. Well, those are very high for myriad reasons in patients that have metabolic impairment and are type 2. But if you can't feel because you have no sensation in your feet, not only are you subjected to a higher level of incidence of ulcer formation, but you're also affected from a proprioception standpoint. So your balance is poor and you fall and you break your hip, and then and that has a big, tremendous amount to do with it. Then if you think about just the pain, a lot of patients with diabetic peripheral neuropathy have incredible difficulty sleeping. So they can go through the day pretty well, but then they get to bed and their symptoms just start driving them crazy, and they have restless leg syndrome to a higher incidence than non-diabetic patients. And so now you've impaired sleep, which is one of the four pillars of health, right? And so how can you have great metabolic health if you have horrible sleep? It's almost impossible.
Sure.
Another factor is that the most common and prevalent symptom of diabetes is actually depression. And people don't talk about that a lot, but you would think that we would talk about it more, but it's kind of one of those things that flies under the radar.
Hmm.
So if your sleep is impaired and you're in pain and you're constantly burning, the likelihood is that you're going to have a higher component of anxiety or depression or both. And so now we've affected another pillar of health, which we could call the spiritual or, the overall well-being pillar, which is so important. And then the other two are, diet and exercise. So now if you have somebody that has tremendous amounts of neuropathic pain, they've got really very little chance of being able to exercise because that's going to likely exacerbate their pain. So now we've affected that. And then the last one would be your nutritional pillar or food pillar. That's something that you can still work on. But if you have all of these other things going on, then that's a hard one to do too, because a lot of people live to eat rather than, eating to live. There's a difference there.
True.
So what we're talking about today, albeit it seems like a very isolated, esoteric topic, it has tremendous ramifications for overall health and well-being.
Sure. And so, for the large population of people who are struggling with diabetes, which is so many people, many around me, when it comes to this solution, what are the solutions people are being given right now for their neuropathy?
Well, for their neuropathy, they're usually given a prescription for gabapentin or pregabalin, which is Neurontin uh, spacing out on Lyrica. So
Okay.
they're either, it's either a Lyrica or Neurontin. And then, sometimes they'll be treated with a tricyclic antidepressant or some other type of medication. Sometimes you mix some of the pain medications in that formula because some of these patients are having tremendous amounts of pain. But
Mm.
most of the time, they're seen and they're getting a prescription for one of those drugs, and it's basically there's nothing else I can do for you. And that is catastrophic because we know that if in the properly selected patient, and I emphasize the word properly selected, okay, this is
Sure.
not a hammer and not everybody is a nail, but in the proper selected patients, more than 90% were able to reduce or eliminate their pain, and more than 75% of the time were able to restore protective sensation. So when they step on that pebble, they'll feel it and they'll take it out of their shoe right away rather than walk on it all day long and develop an ulcer with potential subsequent infection. And then the worst scenario is amputation
Of
down
course.
the line.
Of course. So here's the question. Like, it sounds great. It sounds like my mom needs this and people I know need this. Don't diabetics not heal well? So aren't we usually anti-surgery for them?
Well, that's a myth, actually.
Okay.
Okay. And it depends on what you're doing from a surgical standpoint. But one of the things that we always evaluate is what is the circulation like before we would take anybody to surgery. So they have to have adequate vasculature,
Sure.
at least on a macro scale, before anybody would go to surgery. But interestingly, yeah, they diabetic patients heal slower, but they still heal. You may have to leave the stitches in for 3 weeks versus 2 weeks for a non-diabetic patient. But see, there's a lot of myth that you're subjecting these people to a higher risk. And in actuality, there was a big registry, and I think it was quite a few patients that were enrolled in the registry as far as how many developed postoperative infections and serious complications. And I don't remember the exact percentage, but it was a very, very small amount of people. And we're talking like on the order of 1 or 2%. So it was pretty darn small. So
Yeah.
that is a little bit of a myth that these folks can't tolerate the procedures. But again, I go back, we really evaluate everything before we would subject anybody to it for that matter.
Sure. And if anyone listens to my podcast, they know I'm pretty anti-surgery, I'm pretty anti-medicine. I'm pro any solution that works.
Right,
And sometimes that involves surgery or medications that can step
right,
in and help us get us where we need to be. And then we can look again at the natural alternatives that help us hold the chronic, help us heal and manage the chronic conditions that we have, if not reverse them, which is always the goal. And so it's interesting what you're talking about. You're saying people think of peripheral diabetic neuropathy as unsolvable, unhealable. They throw some drugs at it, but they don't actually believe that it's something that they can heal or help the patient win at. And then you're saying that so many people are struggling with diabetes, and the end game of losing function in our feet and legs can be
right.
disastrous and detrimental. And then you're saying that although there's a misnomer that they don't heal well, um, they do actually heal. And this can be a game changer for them. One of my
Right.
first podcast episodes, I had an orthopedic surgeon on, Dr. Gorin from South Florida, who I love. He's down in Aventura, Hollywood. And he shared, and I found this point so interesting. A lot of people who go for a knee replacement go really late in the game. They waited forever. And
Hmm.
because they waited, they became so sedentary that although they got the surgery and that gave them back their knees, sometimes they don't bounce back and become
Right,
their most active selves again.
right,
And I thought it's so interesting to think of surgery sometimes as the preventive and best solution
right,
and not as the worst last solution. And
right.
so working around doctors for this last 10 years that I have with my product line that I built, I have these different vantage points because I get to hang out with the doctors like you all day and learn, okay, like look at this other perspective and look at the results that we've seen in the patient base. So, what
Right.
are some of those patient stories that you've seen where this solution completely transformed the patient's experience in life after this?
Well, let me interject before I answer that question. So if I get a little too tangential, bring me back to the point, please, because sometimes when we have these conversations, I have a lot of passion and I get like way down another tunnel. It's like,
Me
what's
too.
he doing over there? We want to talk about something over here, right?
Yeah.
But but I'm in the same camp. If I can avoid having to take someone to surgery, that's our ideal. And we work very hard with many different things that are non invasive, or I should say non surgical, like hydrodissection procedures and that type of thing. But you have to think about a peripheral nerve injury, which this is. And it wouldn't be dissimilar to somebody who fell and broke their leg. They have a broken leg. They need to have surgery if that's displaced, or otherwise they're not ever going to heal. So I'm not a big one pill, one disease, one surgery, one. The ideal is that if somebody is suffering from this, we can improve their life greatly with the procedures that we're talking about, but we still want that patient to not eat the sugar, to exercise, to bring them all into health. So it's really, I don't look at it as like, I look at it as part of the whole optimization process versus it's just surgery, right? Because we're taking care of more than just the patient. Now, I was going to get back to a story,
Mm,
right?
yeah.
And you probably might be referring to the gentleman that I referred to in my TED talk, and that was an interesting and so impactful thing for me, because when we don't have a condition, it's very hard for us to get an ideal understanding of what that person is suffering and how badly they're suffering. And sometimes um, we just think that, well, somebody's got a little bit of pain, suck it up, move on, that type of thing. But it's not like that. I mean, these people some of them are so suicidal because of their pain and because they've lost all hope. People have said there's nothing that can be done for you, and in many cases there is something that can be done. And so I think, when Roger, who was that patient that I talked about in the TEDx talk, when he came to me, and he, you know, mid 40s probably, I can't remember exactly how old, but really, an engineer, the whole professional, great family, all this other stuff. And when he came back in for his first post-op visit and said, if it hadn't worked for him, he had already had his suicide plan.
Oh my.
And that really resonated with me. It's like, when they say you saved my life, my first impression is, no, we didn't save your life. We took away some of your neuropathic pain and made your life a little bit better. But then I started understanding in this subset of patients that it is life threatening, not necessarily because of the metabolic disease, which could ultimately get you with what we talked about, increased cardiovascular risks, cancer, those types of things, but just simply because they can't tolerate the pain anymore, and they can't sleep, they can't get any relief. It's a 24/7, and that's their only path to try to find some relief. So then
Sure.
I realized this is not only life changing, it's life saving surgery for some people.
And will you explain again, how does it impact them in their sleep? Is it like you said, restless leg? Is it
Yeah.
burning and itching in their feet?
Yes. So a lot of them can't tolerate anything touching their feet, like a sheet or anything like that. Just drives them crazy. And when they're up and about and walking around, there's other things going on, cognitive things that are probably dampening or down regulating some of all of the impulses, pain impulses that are going to the central nervous system. But then when they try to lay down at night and go to sleep, it's very, very difficult for them.
I've heard of this before, and the person who I'm thinking of, it was inflammation that was the issue. So isn't inflammation playing a major role here? And is it that, yes, although they're inflamed, we can reduce their inflammation, but if you don't physically open the pathway for them, they're not going to get the support they need? Is that the approach that you're taking with the surgery?
Well, so there's a couple things going on, and you're absolutely correct. Inflammation is a big process. I don't know any neurological condition that doesn't have a component of inflammation. So
True.
that's one thing. Now, what's causing that inflammation? Well, obviously some of it is systemic, or maybe a lot of it is systemic, right? So they're eating inflammatory things, their gut microbiome's disturbed, they may have leaky gut. All of these things that we really want to look at and try to improve so that the patient will get benefit. But the other thing that causes inflammation is focal nerve compression. So
Hmm.
if I have a nerve that is pinched, that causes an inflammatory response right there at that site.
True.
Now the interesting thing is that um, it also causes impairment of the microvascular circulation. So where you have a compression, the blood is not perfusing into those neural tissues like it would in a non-compressed state. So by opening that tunnel up, now the blood can get there, and that will help you regulate the inflammatory component. So
Right.
yes, you're absolutely right. There's definitely a component of inflammation.
So, because of the issue, the body is sending inflammation there, clogging up the system, basically, causing more trouble, swelling, all the issues that inflammation can cause, really making it worse, not realizing. And then by decompressing, you're giving the space for the body to flow and do what it needs to do.
Correct. That's correct. And we have wonderful studies that show how much we can improve blood flow
Hmm.
after this surgery. And it's actually immediate. So we can actually measure blood flow in the operating room to the toes, and we're doing procedures up in the leg, and within minutes after those nerves are decompressed, their blood flow increases. Now, another thing that's really important, and many people don't even know this, and I'm talking about surgeons and endocrinologists and that type of thing, but the foot is an incredibly complex structure, machine, really. Okay, and there's this concept or a physiological thing that's called pressure induced vasodilation. So when you put pressure on the sole of your foot, it has a response that goes through the peripheral to the CNS back, and it causes the vessels to open up and to improve the circulation in where the pressure is.
Hmm.
Now, think about that, right? Because I've already said lack of blood flow is a problem, but now we have pressure on the bottom of the foot. And when a patient has protective innervation, then this process that's called pressure-induced vasodilation can occur, and that gets the blood flow to the tissues and keeps them from breaking down. And that's a big component of why we can prevent ulcerations with this type of procedure, because after nerve decompression in the lower extremity, the pressure-induced vasodilation returns. So that's a physiological thing that we were born with, that we lose as we go through this neuropathic process, but then with the surgery, we can restore that process. So that's a pretty cool thing when you think about it.
As you're speaking, I think as an Indian, so many Indians suffer from diabetes. It's like rampant in my culture. You go to India, I feel like everyone's diabetic. I'm sure that's a major exaggeration, but it's something that the population suffers with heavily. I do attribute it to the fact that our diet is way too carb heavy. I'm a vegetarian Indian, so it's like hard to reduce the carbs and eat the protein and do the things. But as you're speaking, I realized how many people around me have feet issues, myself included. I have bunions. I've wore really bad shoes through high school and college. Wish I didn't. So I have those issues. I go to yoga. It's hard to balance and do all the poses sometimes. I get plantar fasciitis if I overdo things. And I think especially this week where my plantar fasciitis is driving me nuts and I can't walk my 10,000 steps a day, we forget how important our feet are until we lose the functionality that we
Mm-hmm.
had before.
Yeah.
And I drill this into my kids all the time. I need you to wear great shoes. You underestimate how much you're going to want and need your feet to be fully functional
Right.
at the end quarter of your life. And that investment starts at the beginning. And so, as a podiatrist, I mean, when you mentioned leaky gut, I thought, wow, this is like functional podiatry.
Right.
You are reaching into the functional medicine toolkit and saying, it's not just your feet. This is your gut. This is your microbiome. This is your metabolism. This is a whole picture around your health. And so, do you have time when you see your patients to kind of get into those topics, and how do they receive it? That's my first question. And my second is, have you seen in the last decades as we go forward that chronic metabolic disease, diabetes, is growing exponentially? And what do you think are some of those underlying causes of that?
Wow, there's a lot to unpack there because you asked some really good questions. But I think the first thing that I would address in what you just said is no one realizes how important feet are until there's some type of impairment or you're deprived of normal function. And then you realize, oh, wow, this is really a big deal. Okay. So when you take somebody's ability to normally ambulate away, you've affected every system in their entire body. If you want to go to the functional medicine point that you brought up, I was basically forced by our patients to get into that space because no one else was doing it. All right. A lot of the people that we would operate on, they would say, I am so much better, but I still have some burning, but I can feel my feet now. I have more normal motor strength. I don't fall. My balance has improved, but is there anything that you could do for the burning? And that's a hard one. That's a hard component to take care of. So we would have to start looking at, start looking and diving into these people, like what else is going on, right? And then so it was one of those things where we could do the same surgery on 10 people and they were, let's say they were all pretty much similar in their medical status and everything, and 7 of them we were like rock stars for them, and the other 3 we were just not, I'm going to say goats, but not in the meaning of greatest of all time. I'm meaning like the goat out in the field. We didn't do much for them, and the answer is because they were still inflamed. They still had all of these other things going on that it was kind of silly for us to believe that we could just simply decompress a nerve peripherally and we would take care of all their problems, and we didn't. So I was forced over the last 20 plus years to start really looking into what are these things going on. Now, a lot of people, and I wish there was a rule that said folks can only have one problem or one disease at one time, because if that was the case, then it would make all of our lives much simpler, right?
It would.
And yeah, but we can't do that. So a lot of these patients have had other issues. They've been exposed to mold, right? No one ever asked them, hey, do you ever have mold in your house? Oh, yeah, man, we had to tear out the wall. It was terrible, blah, blah, blah. We have it under our sink. And then you start testing these folks and they're riddled with all kinds of mold. And then you ask them, well, how's your digestion? Oh, it's terrible. I'm always constipated, or I always have diabetes or diarrhea. I have IBD, whatever, right? And you start testing their gut microbiome and they're all jacked up. They got parasites. They have all of these other things. So those were the things that we had to start looking at. Something as simple as vitamin D, right?
Mhm.
It's like, it's so inexpensive to test for it. It should be a routine test for everyone,
I agree.
but they come in and they have like 10 or 15,
Yeah.
and or even when they come in they have 35 and they say, well, I'm in the normal range. It's like, well, yeah, that's a normal range based on a whole bunch of sick people, but it's not an optimal range at all, right? So how can you get these folks better if you're not really looking at them from a whole functional standpoint? So we got into that. Now, that takes a lot of time, and it's not something that can be done in an office that sees 70 patients in a day and they're just quickly writing out a prescription, because they don't have more than 3 minutes to spend with you. We'll spend, a lot of times, our first office visit, we'll spend more than an hour with the patient because we have to look at all of these different things. So that kind of sums up, I think, the answers to your question.
For sure. And I think the frustration is as the patients, a lot of times we're not getting the time we need and we're not able to share like the whole picture. And so I'm glad you are in your practice able to make that time and take that time with the patient because diabetes is complex. It took time
Hmm.
to create it. It's going to take time to unwind it. And
Right.
with the family history I have, which I think of it as family history and the habits I was taught in my own household. I knew my life was going to be about having to manage not becoming diabetic like my family. And my sister laughs at me.
Right.
She's like, "You are fine. Have you seen your numbers? You're always fine." And I'm like, "Well, I'm fine. But if you understand optimal
Right.
takes work. It takes
Right.
consistent work. It takes an awareness around what we're eating, like you're talking about our gut health, our toxic burden. Um, of mold and these different things, these outside factors, our sleep. And so I really look at optimal health as building each pillar one by one. And
Right.
once you've got them on track, you get to have vibrant health. And then when you get knocked off in any of those pillars, okay, you took a downturn, but that's okay. You can come right back up.
Right.
But I'm so glad you're bringing awareness to this. So, what is the surgery called, and how can someone go about finding a practitioner who does this?
All right, it's a great question. So the surgery is called just nerve decompression. All right, and in the lower extremity there are 4 or 5 nerves that get entrapped, and basically like a carpal tunnel surgery in the hand, where you open it up and take the pressure off the nerve. That's basically what we're able to do in the lower extremity. So we identify those nerves that are affected, and by basically decompressing them, then they can restore their function.
Nice.
And then once that function's restored, almost always the other things get better too. Like the skin quality gets better. You see a lot of diabetic patients, their skin's very dry. It's almost like a cigarette type of paper. And then all of a sudden they come in and they'll say, wow, look, this foot's starting to sweat and it's pink now. So
Yeah.
you've restored the autonomic function to it. Um, and it's all an outpatient procedure. So it's, about an hour and a half to, well, an hour and 15 minutes to an hour and a half to decompress, the sites that need to be decompressed. We let the patients walk that same day. So it's surprisingly it's not a horrible surgery to put people through. We get them back pretty quickly. Now, to get to people that do this work, the best resource is the Association of Extremity Nerve Surgeons, and that is aens.us. And you
Okay.
can go to that, and there's a physician finder, and there's about 200 people out there doing this type of work. And once it catches on, which is my mission now, and it will, because the level 1 studies and numerous studies are there to support this. And like we talked about, the phenomena of reestablishing pressure induced vasodilation, these are very studied things. So it's not like just somebody's out there doing these procedures willy-nilly. There's been a lot of high level study, but for some reason there's still a lot of pushback to it. And I think a lot of that is ignorance and misunderstanding of what's really being done. But that would be the best place for people to go and look.
Perfect. That's so interesting. I love that you came on to my podcast today to share this. Because above all, if we're not going to stay functional and mobile, ambulatory, as you called it, if we can't move and walk and do the things we need to do, we know it's an issue. And so many of us are looking at our aging parents and thinking, I need to keep you functional. I need to make sure you don't
Right.
fall. I need to help you with balance. But I don't think people have really thought about this as an option. And so it's so interesting, especially as someone who's always talking about inflammation and chronic metabolic disease,
Right.
to bring in a solution that just feels like I've never heard of this. And I think most people have never heard of
Right.
this, or they would reach for it more as a solution. So, is there anything that we didn't cover today that you want to cover before we wrap up?
Well, I think that the most important thing to understand about this is that these procedures have been around now for 40 years.
Yeah.
They're very well studied.
Nice.
The data is out there, it's published. Your regular physician, endocrinologist, I mean, I've had many patients that were told point blank by their endocrinologist, it's woo woo, it doesn't work, blah, blah, blah. And they were so desperate that they'd come back and they'd say, my endocrinologist said 100% do not have this, so I'd like to schedule surgery next week. And then they would go back to the endocrinologist and say, hey, look, this foot's normal, because we always do it 1 foot at a time or one leg at a time.
Yeah.
And they would go back and they'd say, I can move my toes on this one. I can feel tickling. I have my sensation back. I don't in this one. So, either, get on board, or I'm going to have to go find a new endocrinologist. And believe it or not, we get a lot of referrals now from endocrinologists that happened, because sometimes it takes the clinician, they can read 100 articles and maybe have a complete agreement with the understanding, the philosophy and everything like that. But until they see that one patient that comes into the office like, oh my God, it really does work, that type of thing. So I would say the most important thing is that if you have diabetic peripheral neuropathy, there is hope. And there are many things that can be done, not always surgical. And that's, we specialize in many things that are not surgical. But if you have the proper medical indications, then this is something that may change your life. So there is hope. I think that's the most important concept.
Absolutely. I think it's so important to give people hope, show them they have options. I always say we are all so bio-individual, so we need to figure out all the tools in the toolkit available to us,
Right.
and then figure out which ones work for us the best. I function
Right.
very differently. I need to always reach into the natural toolkit first. Recently, because of my plantar fasciitis really bothering me and me complaining, someone's like, just get an injection. It'll solve it. And I was like, guys, that's not always the first thing we should reach for. How about, are my tennis shoes needing to change? My custom orthotics might be having issues. Maybe it's a gait issue and I need to address it with chiro. Like, let's go down the list before you just say inject it and be done.
Right.
So,
well, we specialize a lot in heel pain, because that's another neurological and musculoskeletal disorder that's very common.
Right.
But we can talk afterwards. I've got some ideas for you.
Thank you. I'll take any ideas, whatever
Okay.
can get me moving. Because to me, I get all my best creative ideas in motion. I want to hit my step count every day. I love walking in nature, but I want to walk in nature for longer again, like I used to, especially as the weather gets gorgeous outside. So, Dr. Barrett, will you share your website and where people can find you if they want to talk directly with you?
Yeah, probably the best way to get to us is just to go to usneuropathycenters.com.
Okay.
And you can find everything there and reach out. And then again, I'm going to say, I'm really proud of the Nerve Society, the work that they're doing, the training that they're doing. So that's the Association of Extremity Nerve Surgeons, AENS.US.
Awesome. Beautiful. Well, thank you so much for joining me on the podcast today, for sharing on this important topic related to diabetes and supporting people in their health journey. Thank you, everyone in the audience, for listening in today. I hope this was helpful to you. If this episode is supported to you or someone in the family who you know or one of your friends, please share it with whoever needs to hear it so they can get the benefits. Thank you again for joining on the Fusionary Health Podcast. Please like, subscribe, leave a review. That's how we get to share this important information out with the world. And thanks again for joining today.
Thank you.
Thanks for joining me for this episode. Check out our sponsor, Fusionary Formulas, the potent turmeric supplement used by doctors around the U.S. for patients with pain and inflammation. www.fusionaryformulas.com. I'm your host, Dr. Shivani Gupta. For more, visit shivanigupta.com. Subscribe to this podcast in Spotify or Apple Podcasts. Click the follow button or subscribe in any of the apps that you use. That's all I've got for you on the Fusionary Health Podcast this week. You have the power to transform your health and achieve vibrant health starting today.